Hello and welcome to the ASCO Guidelines Podcast, one of ASCO's podcasts, delivering timely information to keep you up to date on the latest changes, challenges, and advances in oncology. You can find all the shows, including this one, at asco.org/podcasts. My name is Brittany Harvey, and today I'm interviewing Dr. Alison Loren from the Perelman School of Medicine of the University of Pennsylvania and Dr. Ann Partridge from Dana-Farber Cancer Institute, co-chairs on Management of Cancer During Pregnancy, ASCO Guideline. Thank you for being here today, Dr. Loren and Dr. Partridge.
Thanks for having us.
Yeah, it's a pleasure.
And then just before we discuss this guideline, I'd like to note that ASCO takes great care in the development of its guidelines, ensuring that the ASCO conflict of interest policy is followed for each guideline. The disclosures of potential conflicts of interest for the guideline panel, including Dr. Partridge and Dr. Loren, who have joined us here today, are available online with the publication of the guideline in the Journal of Clinical Oncology, which is linked in the show notes. So then to dive into the meat of this guideline, to start us off, Dr. Loren, could you provide an overview of the scope and purpose of this new guideline on the optimal management of cancer during pregnancy?
Sure. Thanks, Brittany. So this was really born of, I think, a lot of passion and concern for this really vulnerable patient population. We have observed, and I'm sure it's not any surprise to your audience, that the incidence of cancer in young people is increasing, and simultaneously people are choosing to become pregnant at older ages. And so we're seeing more and more people with a cancer diagnosis during their pregnancy. And for probably obvious reasons, there's really no way to do randomized clinical trials in this population. And so really trying to assemble and articulate the best evidence for safely managing the diagnosis of cancer, the management of cancer once it's confirmed, being thoughtful about, obviously, the health of the mom, but also attending to potential risks to the developing fetus, and really just trying to be really comprehensive and balanced about all the choices for these patients when they're facing some really challenging decisions in a very emotionally fraught environment. And I think it's really emotionally fraught for the providers, too. You know, this is obviously an extremely intense, very emotional set of decisions. And so trying to provide a rudder, essentially, to sort of help people frame the questions and trying to make as evidence-based a set of recommendations as possible.
And I would just add that evidence-based is a strong word here because typically as you just heard, our gold standard evidence is a randomized trial, but you can't do that in this setting in general. And so what we were able to do with the support of the phenomenal ASCO staff was to pull together kind of the world's literature on the safety and outcomes of treatments during pregnancy, as well as consensus opinion. And I think that's a really, really, really critical difference about this particular guideline compared to many of the other ones that ASCO does, where consensus and good judgment needed to kind of rule the day when evidence is not available. So there's a lot of that in our recommendations.
Yeah, that's such a good point. And before we move forward, I just wanted to reflect that the composition of the panel was really broad and wide ranging. We had maternal medicine specialists, we had legal and ethical experts, we had representatives who understand pharmaceutical industry's perspective, and then medical oncologists representing the full spectrum of oncology diagnoses. And so it was a really diverse, in terms of expertise, panel, internationally composed to try to really get the best consensus that we could in the absence of gold standard evidence.
Absolutely. That multidisciplinary panel is really key to developing this guideline. And as you said, looking at the evidence, and even though it doesn't reach the level of randomized trials, still critically evaluating it and reviewing that along with consensus to come up with optimal management for diagnosis and management of cancer during pregnancy. So then to follow that up, I'd like to next review the key recommendations of the guideline across the main sections that the expert panel provided. First, I'll throw this out to either of you, but what are the important general principles for the management of cancer during pregnancy?
I think there were three major principles that we hammer home in the guidelines. One is that this is a team sport. It's multidisciplinary care that's necessary in order to optimize outcomes for the patient and potentially for the fetus. And that you really need to, from the beginning, bring in a coordinated team, including not just oncologists, but obstetricians, maternal fetal medicine specialists, neonatologists, ethics consultants, and obviously the patient and potentially her family. So that I think is one of the most important things. Second would be that obviously in a pregnancy, there are two potential patients, and that the nuances of safety and risk from treatment is really wrapped up in where in the trimester of the pregnancy the patient is diagnosed, along with the kind of cancer that it is, both the urgency of treatment and the risk of the cancer, as well as the potential risks of any given intervention across the cancer continuum. It's a broad guideline in that regard. And then finally, and this is particularly timely given what's going on from a sociopolitical standpoint in the US, really thinking about informed consent and potential ethical as well as legal implications of some of the choices that patients might have when they're thinking about, in particular, continuing a pregnancy or potential termination.
And I'll just add that I think that the key to all of this guidance is nuance and individualization, and also making sure that patients and their care providers understand all the choices that are available to them and also the consequences of those choices. Nobody would choose to receive chemotherapy during pregnancy if that wasn't necessary. So there are risks to treatment, but there are also risks to not treatment, and making sure that in a suboptimal situation where you don't have a lot of evidence, trying to weigh the best you can the risks and benefits of all of the choices so that the patient can come to a decision about the treatment plan that is right for her.
Definitely. And those core concepts really set the stage for individualized care on what is necessary for appropriate multidisciplinary care, prioritizing both patient autonomy and informed decision-making. With those core concepts and key principles in mind, I'd like to move into the recommendations section of the guideline. So what are the key recommendations regarding diagnostic evaluation for pregnant patients with signs or symptoms of cancer?
I think the most important thing is to not delay, that there are very careful and well thought out recommendations for how to evaluate a potential cancer. And while there are certain things that we know can be harmful, particularly when certain dose thresholds are exceeded, for instance, abdominal imaging, there are certain radiographic thresholds that you don't want to exceed because of risk of harm to the embryo or fetus. There are still lots of options for diagnosing cancer during pregnancy. And again, thinking about the costs of not doing versus the costs of doing, right? It's really important to make the diagnosis of cancer if that is a consideration or a concern. And sometimes going directly to biopsies or getting definitive studies, even if there's a small risk to the developing fetus, is really essential, because if the mom doesn't survive, of course, the fetus is also not going to survive. And so we need to be thinking first about the patient who's sitting in front of us, the woman who needs to know what's going on in her body so she can make good decisions about her health. So I think that is a key principle in thinking about this.
Absolutely. So following that diagnosis of a new or recurrent cancer, what is recommended for oncologic management of patients who are diagnosed with cancer during their pregnancy?
So I think the general principle is, again, cancer is such a wide number of diseases, and even within diseases, a range of stages and risks and associated opportunities for risk reduction and or treatment, depending on the kind of cancer. Just by example, in the work that I do, which is breast cancer, once someone's had a surgery in the early stage setting, a lot of our treatment is about risk reduction. And that's very different than from what Alison does, which is treating people with leukemia, where it's kind of binary. If you do not treat, including with cytotoxic drugs, the patient and an unborn fetus will die, especially early in the pregnancy, obviously. So this is where cancers are very, very different. So I think taking the approach of what would you do if the patient were not pregnant, and what is the best treatment for that particular patient with that particular kind of cancer, and then applying the pregnancy and where the patient is in that pregnancy in terms of the trimester of the pregnancy and what's safe and what's unsafe from the options that you would give her if she were not pregnant. And then if the patient is choosing to keep the pregnancy, which in my practice, many people come and they come to me because they want to hold on to their pregnancy and want to figure out how to make it work, coming up with a regimen that tries to give them kind of the best bang for the buck, the best possible breast cancer therapy with the least harm when possible to the fetus. It's a bit of a balance, right? And then we can't always give people the best approach. And sometimes it comes down to making a decision to give up something that may improve their survival so as not to harm the fetus. And sometimes it goes the opposite direction where a patient will say, oh, that's going to improve my survival by 5%, and you can't give it to me now. I'm going to choose to terminate, even though that's obviously a very, very difficult and challenging decision to make in this setting, because they want to optimize their survival and ideally live on to potentially have another pregnancy in the future, if that's something that's of interest to her. So these are really, really hard conversations, as you can imagine, but that's kind of where we go.
Yeah. And I think this is where the need for more research and understanding is really key, because sometimes questions come up. I guess I'm thinking about like HER2-directed agents, which we know are contraindicated in pregnancy. But what about sequencing? Does it matter when you get it? Can you get it later? I think that's something that we don't really fully understand. And similarly, again, this is obviously like a breast cancer and blood cancer focused discussion because that's what we do. But thinking about managing blood cancers, certainly with acute lymphoblastic leukemia, there's actually a lot of options now that, you could potentially use to temporize or sort of get somebody through a pregnancy relatively safely. And I'm focusing on the word relatively because we don't know what the long-term impact might be of potentially not optimal therapy in the long run. And then thinking about other things like timing of a bone marrow transplant relative to either delivery or termination. I mean, again, we really don't know what are the right sets of sort of timing considerations for those. So there's just a lot of unknowns. I think trying to be sort of self-aware and humble and honest about those unknowns so that the patient can engage in the conversation in a way that's meaningful to her and make the decisions that make the most sense for her. I think the most important thing is to make sure that the patient feels supported and safe to make those decisions with as little regret as possible.
Yes, I think it's really important that you mentioned that there's a wide range of cancers here, and that means that care really needs to be individualized for each patient. I'll also note just in this section that I found really informative while reading through the guideline, the lists of oncologic agents that may be offered in each individual trimester, whether it's contraindicated or it can be used with caution, or if there's relatively good safety data on it for prioritizing maternal treatment needs and balancing fetal safety at the same time. I think that's really key. And I think readers will really like that section of the guideline to provide concrete information for them and their patients.
Thank you. We actually spent a lot of time on that table and just thinking about what it should look like, what the format ought to be, what the language ought to be. Because of course, at the end of the day, everything should be used with caution. So what does that actually mean? And we sort of tried to explicate that a little bit in like the footnotes. We really tried to leverage what we know from clinical experience, from package labels, from mechanism of action to try to be as clear and definitive as we could be without overstating or understating what we know.
Yeah, and I think we're focusing on breast and leukemia because that's what we do. But the truth is, much of the data comes from those two areas. Leukemia, not because it's so common, but because you don't really have choices,
right,
to treat or not treat. And so for decades, they've been treating and saying, we hope the progeny comes out okay. And for many agents, it does. The babies are okay. And so we have reasonable observational data. And then in breast cancer, there have been actually some prospective registry type studies where people have been followed and treated when pregnant, and the progeny have been accounted for. And so we have some good experience in that way too. Again, not randomized trials, but at least data that suggests certain agents are safe. And increasingly, because of that, when we've had to treat patients, we've said, okay, let's do it on this registry so that we can at least learn from every patient that comes in this situation. And so I think we will have more and more data given the growing number of young adults with cancer and the delays in childbearing that are happening around the world, and particularly in westernized countries. I wish we didn't. We wish we didn't see this problem. But of course, when we do, we have to make sure that we learn from it and try and get patients enrolled in these registries and any kinds of studies that are available.
Yeah, I'll just underscore that to say that, there's outcomes of pregnancy and then there's outcomes of pregnancy, right? So there's like, okay, the baby was born with 10 fingers and 10 toes. They passed their APGAR and they're doing all their developmental processes along the way. But what happens when they're 10 or 15 or 20? Are they maturing normally? Are they cognitively intact? And then, of course, it's really inseparable from what is the impact on a family of having the mom with cancer, and how does that impact childhood development and intellectual development? And so these are really, really important questions that are very difficult to answer given the longitudinal information that you need. But it's a really critical question that, patients ask and we don't know the answer.
Yeah, that actually leads me to one of the important principles in the guideline that's a little bit of a change from when I first started practicing, which is we have learned from the wider neonatology literature as they've followed up on the children that were born prematurely, that it's actually better not to be premature and to keep the baby in utero as long as it's safe for the fetus and the mother, as long as possible, ideally to term, rather than delivering early and then giving the chemo after that or separating the chemo from before and after. We used to try and deliver early and then give agents, but now we typically will give agents that are safe to be given at the end of pregnancy, ideally close to term, a couple weeks out, to allow for the ability of count recovery. And you don't want to go into preterm labor with chemotherapy on board. But we used to go much earlier and have an argument with our maternal fetal medicine doctors. How early can you get them out? And they'd say, how long can they stay in? And increasingly, we've been able to try and compromise to go even later and allow the fetus to go to term because of the neonatal outcomes that in longer term, there's a suggestion that the children are developing better in the long run if they are kept in utero for as long as possible.
Yeah, that's such a great point. I think that's probably the most important thing for people to take away for anyone who sort of does this. I mean, no one does this regularly because it's a rare event, although I think it's increasing, as I mentioned. But this idea that the third trimester, as most of us know, is primarily a time for growth. Most of the critical development has already occurred. And so administering most chemotherapy agents towards the end of the third trimester seems to be preferable long-term than delivering them early. So that is a really big change, I think. We used to try to sort of, get them to 30 or 32 weeks and then deliver, but we really are trying to get them closer to term, 37 weeks or more, and then coordinating the treatment so that they're not natering, as Anne said, at the time of planned delivery.
Yes, and that's a really important point related to evidence-based care and why we've changed that practice. And so then that actually leads nicely into my next question. But as you both mentioned, this is an important collaboration between oncologists and obstetricians. So the next section of the guideline addresses obstetrical practice. And so beyond what is standard, what additional recommendations are there in obstetrical management for pregnant patients with cancer?
That's a great question. So I will say we were really struggling with how much do we cover? This is an oncology guideline. We are not obstetricians. We certainly had great representation from our maternal fetal medicine colleagues on the panel, but really trying to sort of give useful information without overstepping. And so I think the main recommendations are to increase the frequency of fetal monitoring, make sure that there's close attention to blood counts in the patient. But I think there's really still a gap in terms of what we know about optimal management of a pregnant person who's receiving therapy and how to handle the pregnancy itself. The delivery should be a usual delivery. Our colleagues did not recommend a planned C-section. They recommended usual care in terms of planning for the delivery. Obviously, if a C-section is indicated, then it should be done, but it shouldn't be planned this way because of the cancer diagnosis. And I guess the other thing that we mentioned in the guideline, although we were reluctant to push it too hard because of access to these specialized services, was evaluating the placenta after birth to ensure that there were no metastases in the placenta itself.
Those are the main things. And judicious and prudent obstetrical care, as I think, is trying to be practiced regularly with MFM. Typically, these patients should be followed not by your average OBGYN, but a maternal fetal medicine specialist, because these patients will have special concerns, especially if they're sick.
Yeah.
So oftentimes, especially Allison's patients are actually sick with leukemia. And so you're monitoring them a lot. Whereas, a breast cancer patient typically isn't sick, although they could get sick with their chemotherapy. And so we really want to hand in hand manage these patients with our MFM colleagues.
I think we also highlighted in the guideline, just for the refresher purposes of the oncology community generally, which drugs that would be given in a normal oncology setting are safe to be given to a pregnant person. So we talk a little bit about what kinds of steroids are recommended, antiemetics, DVT prophylaxis, peripartum. These are things that we think about a lot in oncology, but just wanted to make sure that it sort of intersected appropriately with the care of a pregnant patient.
Definitely. That specialized care is really important for patients who are pregnant and have cancer. And then the last section of the recommendations addresses psychological and social support. As you both mentioned before, this is a highly emotional time. It can be difficult and challenging to make decisions. So what is recommended for the psychological and social support of pregnant patients with cancer?
Well, as I said, it's really something that needs to be considered at the beginning through the diagnostic period, all the way into survivorship. Ironically, even though it's a highly fraught emotional situation, I find that my pregnant patients actually are extraordinarily resilient. And what they're really focused on often is the safety of the fetus. Because again, many of the people that come to me, it's a highly wanted pregnancy. They're also focused on their own health, of course. And often you need to bring in social work, sometimes a psychologist, professionals who are there just to help manage their emotions while we're focusing on what do they need medically to be as healthy as possible, both for the mother, the patient, and the fetus. It is very tricky. And I will say also bringing in sometimes people on the ethics team in the hospital to help, both from are you recommending and giving something that is safe? That's number one. And then number two, sometimes patients want to be treated with drugs that we don't have any safety data for in pregnancy. What are our obligations? I think most of us would say we would not treat someone if we don't have safety data and there's suspicion for concern. But where is that line in terms of the right thing to do by that patient? And so we're all beholden to our ethics colleagues to help us when we make decisions like that. We all want to do right by the patient, but we have to uphold our oaths and legal obligations. I don't know if you have to add around that.
Yeah,
It's
no,
very tricky. I can't even talk about it.
It is. It's very hard. I mean, I think, there's a lot of emotion. Obviously, any cancer diagnosis is extremely charged, and people are already sort of in a heightened, they're anticipating a new baby and planning around that. And so it's just an extremely disruptive is the smallest word I can think of to describe it. And I think often there's a co-parent, there might be parents and in-laws and other siblings, and then there's care after delivery. And so it's just a very complex set of dynamics, and having both our ethics colleagues and our psychology and social work colleagues to sort of just pitch in and make sure that the patient is being supported. I think there's sometimes really difficult situations where maybe what the patient wants is different from what the father of the baby wants or what the rest of the family wants. And so that can be really challenging. You never really know where those landmines are going to pop up. So it's good to have the team on board early and often.
Yeah, I would add to that. The other thing here that I think is really important, like in all of medicine, but especially in situations like this is where we have to be very careful as professionals not to impose our own ethical, moral, emotional, personal views on the patient, and to try to reserve judgment as much as possible. We are their navigator with the most important evidence and information that we can provide in the current situation. And that's where this guideline is extraordinarily helpful, we hope, for clinicians in the years to come. And at the same time, we can't necessarily impose our own views and what we would do on a patient or what we tell our daughters, sisters, friends, family members. It's very tricky in that way. And so sometimes not just support for the patient, but support for the care team may be warranted in some of these very fraught situations.
Yeah, that's such a great point. I was sort of thinking that too. Like, it's of course the patient is front and center, but these are really difficult situations to navigate. And I'll just add also that a lot of times these patients end up in academic centers, which I think that's where the expertise or even just the experience may be. But the downside of that is that, the teams are constantly changing. You have a new resident, you have a new intern, you have a new attending, a new fellow. And so, the patients may be subjected to lots of different ways of communicating. And sometimes those perceived differences can be really challenging. So sort of team huddles to sort of make sure that everybody is reading from the same script and everyone's comfortable with how the information is being presented so that the patient doesn't feel more confused or more overwhelmed, that they're kind of getting a consistent message from the whole team that this is what we know, this is what we're recommending, here are your other choices, and here are the pros and cons of each of these options.
Yes, I think you've both touched on this, and that bringing in appropriate experts to support both clinicians and patients and their decision making and their mental health is really important for this section of the guideline. We've already discussed this a fair bit throughout our conversation, but in your view, what is the importance of this guideline and how will it impact both clinicians and pregnant patients diagnosed with cancer?
I can start with that. We just talked about experts and having them all around, but the fact is most people don't have the experts all around when they're dealing with this. And I think this is an expert-based, evidence-based guideline where having this in one's back pocket, whether you're in rural Montana or at a major cancer center on either coast, you will be armed with the latest and the greatest in terms of what we know and what we don't know, and some very helpful algorithms for how to think through the process of dealing with a patient who's diagnosed during pregnancy, whichever type of cancer it is. We couldn't cover every single specific thing about every cancer, although it is a pretty long guideline and there's a lot of nuance in there. So you might find a lot about specific cancers. And I think that that'll be very, very helpful for people who are faced with this situation in the clinics, just to frame it out, think through. Sometimes there is no answer that's the perfect answer. And then, using this as kind of a scaffolding and phoning a friend who may have more experience to help guide you and guide the patient, most importantly. I think it'll be very helpful in that regard.
Yeah, I think so too. I've talked about that we're working on this guideline, and the anecdotal feedback has been, this is so helpful. Like, there really hasn't been, I think, an all-in-one place, diagnostic considerations, radiographic considerations, staging, treatment, all the modalities, surgical, radiation, systemic chemotherapy. We try to include, when we could, novel agents, including targeted agents and monoclonal antibodies and bispecifics and cellular immunotherapies and non-cellular immunotherapies. We really, really tried to cover in 2025, what are people using to treat cancer, and to try to give the most balanced view of what we think is safe or reasonably safe, and what we think is either unproven or known to be risky, really to have it be kind of a go-to, all-in-one, as much information as we have about these really challenging cases. We tried to include and mentioned, specific cancers. And I think when there were specific things to shout out with specific cancers, we really tried to highlight that. Okay, lots of young patients with cancer have Hodgkin's lymphoma. So what's safe and what's not for that specific case, or what's safe or what's not when you're thinking about colon cancers. And we have a shout out in here about considering checking for DPD deficiencies in patients who are pregnant. I know it's generally recommended nowadays, but certainly for people who are pregnant, you really want to avoid excess toxicity. So I think just really trying to be attentive to specifics about certain cancers in young patients and what would be valuable for a practicing oncologist and obstetrician to know when you're faced with the situation.
Yeah, and I think the other critical thing that's great about this guideline is it's a starting place. And I anticipate that we will be building on this guideline for many years to come. And remember that when first, I wasn't around then, but probably 3 or 4 decades ago, when chemotherapy was just coming out and patients were coming in pregnant, there was a feeling, I'm sure, that was, we can't give this to this person because it's purposefully going to destroy cells. And when you destroy cells in a growing fetus, you're going to destroy or harm that fetus. And yet people didn't have great choices. It was get treated or die, especially with things like leukemia early on.
Right.
And bold patients, along with their oncologist, said, bring it on. And that's how some of this literature has been born. And so moving forward, there will be either purposeful exposures or inadvertent exposures of some of our therapies where we will learn ultimately. And this is a place where we can update these guidelines. That's the beautiful thing about the ASCO guidelines, is that they're constantly being thought about to be updated. And then when there's enough of a change in practice, they will be updated such that we will continue to inform how we do this in the years to come for our patients who come in pregnant.
Yeah. And I'll say I've been doing this long enough now. We were just talking about a different guideline, the fertility guideline earlier today. And over the 20 years that the fertility guidelines have been out, just the amount of research has really skyrocketed. And you can see as you look at each guideline, how much we've learned, what we can say, yes, this is working. No, this isn't working. Like it's stuff that we used to say, oh, we don't really know. And now we have answers. I think I speak for both of us when I say that we're hopeful that this will serve, as Anne said, as a starting off point and really inspire people to ask the questions and do the research so that we can give better guidance moving forward. Really trying to think about, mechanisms and leaning on our colleagues in pharma and in the government who sort of think about safety and efficacy to sort of make sure that they're contemplating not just non-pregnant patients, but also pregnant patients, or as they're thinking about marking the package inserts with safety guidelines around this.
Yes, this is a critically important first guideline on the management of cancer during pregnancy, and we'll look forward to continuing to build on that. I think, as you mentioned, this guideline is far-reaching and has a lot of recommendations on it. And so both the full text of the guideline and those at-a-glance algorithms, figures, and tables will be really useful for clinicians in their clinic. Finally, to wrap us up, we've just been discussing this a little bit, but specifically, what are the outstanding questions on the management of pregnant patients with cancer, and where is this further research needed?
There's lots and lots and lots of unanswered questions. And I think if you look at the table, most of what we say is, we're pretty sure this is okay. We're not so sure about this. I'm paraphrasing, but we really just are operating in a paucity of what we would normally consider gold standard evidence. It's hard to imagine, of course, that there would ever be, as we mentioned in the beginning, randomized trials. But I think that preclinical data, mechanistic data, trying to think about including, as we go through animal data, making sure that we're looking at female animals and pregnant animals so that we can sort of fully understand what the impact may be. And then I think thinking about more localized therapies around sort of radiation, we're now moving into really hyper-focused radiation treatments like protons. Is that better because there's less scatter? I think those are real considerations that we just don't know the answer to. What do you think?
I think so many unanswered questions. And this is a call to action to continue to and increase the documentation of the experiences and outcomes for patients diagnosed during pregnancy.
Yeah. And I think the long-term outcomes too are really going to be critical.
Yes, we'll look forward to learning about more evidence across the spectrum of care to inform future updates to this guideline. So I want to thank you both so much for your work to develop this guideline, to review the extensive amounts of literature that you did, and work to create this guideline. And thank you also for your time today, Dr. Loren and Dr. Partridge.
Thanks. It was fun.
Yeah, thank you.
And finally, thank you to all of our listeners for tuning in to the ASCO Guidelines podcast. To read the full guideline, go to www.asco.org/survivorship-guidelines. You can also find many of our guidelines and interactive resources in the free ASCO Guidelines app, which is available in the Apple App Store or the Google Play Store. If you have enjoyed what you've heard today, please rate and review the podcast and be sure to subscribe so you never miss an episode.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.